Good morning, everyone. My name is Candace Brimner, and I am the Implementation Coordinator for the Concurrent Disorders Capacity Building Strategy. For those of you who are not familiar with us, the Concurrent Disorders Capacity Building Strategy is a project of the Hamilton, Niagara, Haldeman, Brant, Lynn. The goal of this project is to build concurrent disorders capacity within existing community-based services. One of the ways we do so is by offering educational sessions at no cost. Our educational sessions are broken down into 3 categories: beginner, intermediate, and advanced. Today, we partnered with our friends at the Boris Center for Addictions Research to offer an advanced session on implementing standardized screening instruments for concurrent disorders in outpatient and inpatient settings. So, without further ado, I offer you Dr. Michael Amlung and his lovely research assistant, Ms. Carmen McPherson.
Good afternoon, everyone. As Candace mentioned, I'm Dr. Michael Amlung. I'm a research psychologist in the Concurrent Disorders program at St. Joseph's Healthcare Hamilton, as well as a professor in the Department of Psychiatry at McMaster. And I'm also a faculty member at the Boris Center for Addictions Research. And with me today, we have our moderator. This is Carmen McPherson. She's a research assistant in our Concurrent Disorders program here at St. Joe's, as well as the Boris Center. So today we have 3 main learning objectives in the webinar. First, we're going to learn about validated methods for efficient screening for addictive behavior and mental health disorders in a concurrent disorder setting. Then we're going to tell you about a pilot project that we've implemented here at St. Joseph's Healthcare Hamilton in our concurrent disorders program for standardized screening of individuals coming through the outpatient and inpatient clinics. And then we'll close with learning about some challenges that we've encountered with this project and some strategies for addressing these challenges. So to achieve these learning objectives, we're going to go through these 5 main points today. I'm assuming that the majority of people listening have some background or foundational knowledge in concurrent disorders, but I'm going to give a brief overview of that just so everybody's on the same page. Then I'm going to tell you about our program specifically here at St. Joe's, so our concurrent disorders program, as well as the Boris Center for Addictions Research, and this unique partnership that we have between a research enterprise and a clinical unit. Then we're going to spend the bulk of our time on the next 2 points, which first we're going to introduce the importance of standardized assessment and screening for concurrent disorders, what you can learn, what you can't learn, what the value of that type of a standardized assessment is. Then we're going to go through our pilot project that we've implemented here at St. Joe's, our screening battery, tell you about the format of the battery, what we've found so far with our outpatient and inpatient clients. And then we'll finish with some challenges and lessons learned through the implementation of this and where we're going into the future. So let's start with a brief overview of concurrent disorders. So by definition, a concurrent disorder is a condition in which an individual has both a mental illness and is also experiencing harmful involvement with alcohol, drugs, or other forms of addictive behavior. And the terminology isn't always consistent. In Canada, we often refer to these as concurrent disorders, but elsewhere they might be known as dual diagnosis, comorbid disorder, or co-occurring disorder. And this is a quote from Minkoff in 2001. It's a long quote, but I think it's an important one. They say that for each individual at any point in time, the correct intervention must be individualized according to that person's subgroup, diagnosis, stage of treatment or state of change, phase of recovery, need for continuity, extent of disability, availability, or external contingencies, such as legal problems, and the level of care assessment. And the important thing here is that it must be individualized. These are very complex cases, and so an individualized or personalized approach is really what we need. So the research tells us that people with concurrent disorders are more likely to seek treatment more often than those struggling with either an addiction or a mental health problem alone. And these individuals also are more likely to have worse outcomes in treatment. So they may have more addiction relapses, be more likely to show non-response or reduced response to psychiatric medication. They're more likely to experience hospitalizations and place a greater burden on emergency departments, as well as having a greater rate of suicide attempts and even completed suicide. Often when we think about concurrent disorders, we often rely on this quadrant model that was adapted from Skinner's Treating Concurrent Disorders, a Guide for Counselors. So along the vertical here, we have the severity of the substance use disorder, ranging from low severity to high severity. And on the horizontal, we have the severity of the other psychiatric disorder, again ranging from low severity to high severity. And the section of this quadrant that we're most targeting with our program here at St. Joe's is this high-high. so the quadrant 4, individuals that have high substance use disorder severity and high psychiatric disorder severity. And these are the individuals that really do require an integrated concurrent disorder treatment plan. Okay, so now we have a bit of information about the background on concurrent disorders. What I want to do now is tell you about our program here at St. Joe's, as well as the Peter Boris Center for Addictions Research. So we are located at the West 5th site of St. Joseph's Healthcare Hamilton. This is a $1 billion tertiary psychiatric hospital that opened in February 2014. There's a picture of our facility. It's a wonderful facility, very person-centered, very humanistic in its approach, lots of natural light, lots of programming to really bring the human element into treatment and care. The hospital is probably around 90% mental health care, and then there's also some general medical clinics here at the hospital. In terms of our role here at the hospital, we have both an outpatient and inpatient clinic that is based, again, here at the West 5th site. And in terms of the concurrent disorder program specifically, as I just said, we serve individuals in a 20-bed unit for inpatients. We also have an outpatient team that's made up of a variety of clinical staff ranging from addiction workers, occupational therapists, to psychiatrists. We also have a capacity building team here at St. Joe's, and the role of the CAP building team is to increase capacity around concurrent disorders for the various units of the hospital. So they go and give consults and assessments for mood disorders, anxiety, schizophrenia, etc. And then we are also an active participant in the concurrent disorders capacity building strategy that's LIN-wide, and so we're actively involved in that as well.
Over the last 2 years, one of the things that we've established here at St. Joe's is a unique partnership with a research center that's based here at the hospital, known as the Peter Boris Center for Addictions Research. And the Peter Boris Center was founded by a generous gift by the Boris family to establish a state-of-the-art research center at St. Joseph's Healthcare Hamilton, focusing on the causes, consequences, and treatment of addiction. And our main principles are innovation in research and treatment, translation of basic research findings into improved diagnosis, treatment, and outcomes, collaboration between different units of the hospital, as well as providing education to both learners here at the hospital, staff, clinicians, as well as the greater community through things like this webinar. So it truly is a collaborative model that we've tried to establish. We have on the one side the clinical arm, which is the Concurrent Disorders Program, and we at the Boris Center are providing the research expertise to be more evidence-informed, to be more grounded in what the scientific literature says for best practices for treatment and assessment of concurrent disorders. Okay, so now we're going to get to the actual primary content of what we hope to accomplish today. And we're going to go through some material talking about, hopefully what I hope to convey to you is the importance of standardized assessment and screening, and the value of this and what you can learn from it, what you may not be able to learn from it, what are some options for things you might be able to do to implement standardized screening at different levels, what might a kind of gold standard model look like if you were to implement this in your center. So in order to do this, I want to start by talking about a hypothetical case example. So this is Susan. She's a 25-year-old female, and she was referred to our outpatient team here at Concurrent Disorders at St. Joseph's Healthcare Hamilton. She was referred by our primary care physician for evaluation and treatment for a suspected concurrent disorder. So the question often comes, I am personally a research psychologist myself, so I talk to several of my colleagues about, if somebody comes into your room, into your office for an initial assessment, what do you know about that person? And the response that I got from several people on our team was, it really varies. Sometimes we know a lot about the person. If they've been somebody who's been through our clinic before, maybe they were an inpatient in our inpatient unit, maybe there's somebody that we've been seeing for many years, or they've been in the system for a while, so we have a lot of their records from those facilities. So in those cases, we know a lot about this person. We know their background, we know what their unique struggles are, we maybe know what treatments have worked for them in the past, what ones haven't worked. But the bottom line is, this person is not a stranger to us. We know who Susan is. And there were other cases where the clinicians told us, sometimes somebody might come through with very limited information. We may know next to nothing about this person. or we may know very minimal things from the referring physician or the referring treatment provider. And so you're faced with a challenge as a clinician in terms of who is this person, how can I best tailor my assessments and my treatment and the services we're going to offer to this individual, knowing in some cases very little about the person. And that's where I think a standardized assessment of some sort can really be valuable. And so if you think about a standardized screening assessment for everybody that comes through your particular clinic or your hospital or your community mental health center, there's certain things that a standardized assessment can do for you. One of the things that we think it can do, and it's been proven to be the case here, is it can provide you with a quick snapshot of who that person is at this point in time. And sometimes it can help to fill in gaps in your knowledge about that person. So again, if you maybe received incomplete information from the referral source, it might help to provide some of that missing information. We also think it's valuable because it might clue you into specific features that you previously didn't know. So if you ask somebody, for example, about experiences with trauma or things they may be experiencing related to PTSD, they maybe haven't been asked that before because it wasn't a primary feature of what they were receiving treatment for in the past. And you may miss that as part of your treatment. But if you had a standardized screener that was really brief and somebody flagged high for that, now you know something about that person that maybe you didn't before. And one thing that we're trying to do here at St. Joe's is to possibly use standardized screening information as a way to steer people into individualized or personalized care paths. So somebody who, for instance, is maybe high on opiate use disorder symptoms might be better channeled into treatment services that are geared toward that. Or somebody that's high on motion regulation problems may be better served to be sent to groups that focus on that sort of aspect of that particular person. We haven't quite got that far yet in terms of having formalized care paths, but that's in the future. So that's all the things that a standardized assessment could do for you. But I think it's important to also emphasize the things that a standardized assessment screening will not do for you. And so I think it's important that everybody understands that a standardized screening will not tell you everything about the person. That's impossible. We can't possibly know everything about this person's presentation, about their history, about the problems they're dealing with from a simple 20-minute screening. It also will not provide a diagnosis. And this is something that we stress very strongly with both our clinical staff and our clients, is that we're not using this to diagnose you. We're using this to inform your treatment team's assessment. So it does not take the place of a thorough clinical assessment that would need to be done by your treatment team. So there's pros and cons to a standardized clinical screening. We think it provides useful information, but it doesn't tell you everything. And the question for you is, which elements of this are most important? If you need to get to a diagnosis very fast and that's what's most important to you, the standardized screening may not be as useful. But if you think it's important to get a good picture of who this person is to help guide your assessment, then the things we're going to talk about today might be very useful for you. So there's a number of considerations whenever you pick an assessment. And we're going to talk through several different examples of assessments and what some of the strengths and weaknesses are. But I think there's 4 or 5 key features that you always have to consider when you're picking out an assessment. And I think the most important above all is whether or not the measure is valid or not. You have to be very careful that if you're going to use a standardized screening instrument, you want to pick one that's been psychometrically validated in the literature. So is it something that has undergone rigorous scientific research to determine that this is a valid screening measure? It's both externally and internally valid measure of whatever construct it's assessing. So if it's a depression scale, has it been studied and has it been shown to be a valid indicator of depression? So does it have good psychometric properties? Also, does it come with cutoff values? So is it just a total score, but does the manual or the papers that were based on this tell you, are there thresholds for mild, moderate, severe, high, medium, low, etc.? What are those cutoff values, and are they applicable to your particular population? I think another concern also is the time and the length and the brevity of the measures. There are several measures out there that we would love to do with our clients in the concurrent concurrent disorders program. And we would love to have them do all of these, but the issue is if they're all 40 items each, we can't possibly do all of those particular measures. So we have to pick the ones that balance the length of the assessment with the level of burden to our patients. In our case, we have them usually come about 20 minutes before their appointment to fill out the screening battery. It's not practical to use a battery if it's going to take an hour to complete, for example. Another consideration is in terms of the resolution of the number of items. So is it necessary to use a 30-item questionnaire if there's a 5-item questionnaire that's been equally shown to be equally as valid? It's shorter, it's less of a burden on the individual, and it can still provide you with meaningful information. So again, what level of precision do you need? And what I think you're going to see in a moment is that we tend to use a stepped approach to this. We might start with a very low resolution measure, and then if we find that somebody endorses a particular type of addictive behavior or mental health issue, we might follow up with more extensive screeners. And then the last thing, of course, is cost. So healthcare systems are obviously very strapped for cash. They're dealing with limited budgets. And so, some of the measures we might like to do on every single person that comes through the door are not feasible from a cost standpoint. What we've been able to do is find a battery of publicly available, open source, they're all published, but they're publicly, freely available screener measures that are part of the scientific literature that can be used as screeners for essentially no cost. So hopefully you'll be able to find ways to implement screeners in your program that will keep the costs low and not put unnecessary burden either on your personal practice or your program. So thinking about assessment, I like to think of assessment in terms of being on a spectrum. Okay, so one of my colleagues likes to use this example of vehicles, right? So on the far left, you have your very basic Vespa motor scooter, right? So that's kind of your day-to-day, very simple, get me from point A to point B type of transportation. And on the far right, we have what looks like a Cadillac Escalade SUV here. It's gold painted with flashy rims. So that might be your gold standard measure that you would like to do with every person, but maybe that's not feasible because they take too long or they're too expensive or they demand too many resources. And in the middle, you might have your Ford Focus. And it's not quite your scooter, but it's also not quite your gold standard. And what I want to convey is my background and my training is primarily as an addictions researcher. So today, when we go through some examples of assessments, we're primarily going to be focusing on assessments of addictive behavior. But I hope that what you can take from this is a way of thinking about assessment that then you can apply to measures that are geared toward other psychiatric disorders. I don't feel like I'm particularly qualified to really speak to the pros and cons of mental health scales outside of addictions. So it'll more just be a lessons learned that then you can hopefully use that knowledge and that lens to look at assessments for other things. The convenient thing about thinking about assessment from this standpoint is it sets itself up to finding assessments that fit into each of these categories. So let's start with our moped or our Vespa scooter. So in the case of addictive behavior, we often think of the most simple way of assessing substance involvement is just quantity frequency. So can we just get a simple, quick assessment of how often and how much people are using? So one way to do that is by using the alcohol, smoking, and substance involvement screening test, or what's known as the ASSIST. This was developed by the World Health Organization, and the National Institute on Drug Abuse in the States has made a modified version of this. It's often referred to as the NIDA modified ASSIST, or just simply the modified ASSIST. And there's an item on the modified ASSIST that asks about frequency of use of alcohol, tobacco, and other drugs. And it looks like this. So this one only has the drugs, but you can easily add alcohol and other things. So the idea is, in the past 3 months, how often have you used the substances you mentioned? Whether that's your first drug, your second drug. Usually there's a screener that happens before this, but the idea is this. They would report for each of these categories of substances, and you can see it gives specific either street names or trade names or drug names here. Anywhere from never to daily or almost daily for these. And you can use this information one of a couple ways. You can sum up these numbers, and it'll give you a total score of essentially severity of involvement with quantity, frequency of use. You can use this to point out specific substances that might be a problem for this person, and you can use that to guide future assessment. Just to point out, there is a link there. It wouldn't fit, so I made it vertical, but on the right side of the screen, we will be posting PDF versions of these slides. There's a link right there to the NIDA Assist through the National Institute of Drug Abuse in the States that you can use to download this measure. If you're talking about alcohol use, you can use what's known as the Daily Drinking Questionnaire, or the DDQ. And this is a simple 7-item measure. You simply ask your clients, how many drinks do you have on a typical Monday, typical Tuesday, Wednesday, Thursday, Friday, etc. And this allows you to look at standard drink consumption. So this is from the Canadian Centre on Substance Abuse, and it's important to remind our individuals what we mean by a drink. By a drink, we essentially mean a 12-ounce beer or a cooler, a 5-ounce glass of wine, or a mixed drink containing 1.5 ounces of hard liquor. And I think that's important to remind our clients that even though they may drink glasses of wine, they may not be pouring 5-ounce glasses. So they need to think about it in terms of maybe they're actually drinking 1.5 or 2 glasses with each one that they're having. By doing this, it allows us to add up their total drinks per week, and we can compare those back to the low-risk drinking guidelines that the Canadian Centre on Substance Abuse has suggested. You can also look at heavy episodic drinking or binge drinking, which would be 5 or 4 or more drinks for men and women. You can look at what's known as periodicity. So is this person a daily drinker? Are they a weekend-only drinker? Are there certain days of the week that they tend to drink more? Maybe they go to a happy hour every single Wednesday. You would be able to know that based on this sort of information. We're talking about smoking behavior or tobacco use. You can simply ask individuals, how many cigarettes do you smoke per day? How many do you smoke per week? The important thing here is to assess the quantity of smoking or the behavior rather than just simply saying, are you a smoker? Because in our research, we find there's a wide range of what people identify as being a smoker. If I only smoke 5 cigarettes a day, I might be very different from somebody who smokes 2 packs a day, for example. So it's important to not only get status, smoker, non-smoker, but also how much are they smoking. So those are very simple, quick assessments of alcohol, tobacco, and drug use. They tell you about the quantity and some information about the frequency. But what they don't provide is any information about severity of problems, consequences they may have experienced, associations with other forms of mental health, etc. To get to that, we kind of need to move up to the next level of assessment, which would be our forward focus in this case. So here we're going to add a little bit of complexity. We're going to add maybe a little bit of length to the assessments, but it's going to give us more information about about this particular person's situation. So we have some brief assessments of problematic involvement with substances, for example. And one of the leading ones that's used in terms of alcohol is known as the audit, or the Alcohol Use Disorders Identification Test. Again, this is freely available from the World Health Organization. The website is right there. It's made up of 10 items that you can either administer as an interview. So in the manual, they have an interview version, and they also have a self-report version. And so if you would rather do a self-report questionnaire that somebody could fill out either on a computer or in paper pencil, you could do that. It's relatively easy to score. And what you get is a total score, and then there are cutoffs that are recommended, whether it's higher than 6 or higher than 8. There's some debate on that. But it would tell you whether this person is at least in a range of problematic use. One of the things that often comes up is that this is not meant to be a diagnosis of alcohol use disorder. It's meant to be a screener that will tell you whether somebody's in the range of possibly having an alcohol use disorder. So these are the domains and the content of the audit. So there's 3 essential domains: hazardous alcohol use, and that's frequency of drinking, typical quantity when they drink, and frequency of heavy drinking. We have symptoms of what used to be known as dependence, so impaired control over drinking, increased salience of drinking, drinking in the morning, for example, and as well as harmful or risky alcohol use, so experiencing guilt, experiencing blackout, injuries, or other consequences related to alcohol, and other people being concerned or raising issues about one's drinking. So they answer questions related to those 10 content areas, and then you would receive a total score. Now this audit has been adapted to also have a version for cannabis. So there is known as the QDIT R, and the citations are down there at the bottom. To look this one up again, it's 8 items, and the cutoff for that would be 13. Relatively short, but it provides many of the same domains as the audit, but specific to cannabis use. There's a DUDIT, which is known as the Drug Use Disorder Identification Test. This is not substance specific. This is just general substance use. It's 10 items. But you could, if you were so inclined, you could ask somebody, answer these questions specifically to your use of methamphetamine, for example, and then you would get a substance specific. But the sort of out-of-the-box DUDIT is just general substance use related to drugs. And then if you're interested in assessing level of nicotine dependence, you can use the Fagerstrom test of nicotine dependence, or the FTND. Again, very short, 6 items. Assesses not only quantity and frequency of smoking, but it assesses things like, if you were sick, would you still smoke? Which cigarette would you most like to give up, the first one or the rest throughout the day? And then you can see, you essentially get a score from 0 to 10, and you could be in one of these severity categories that might, again, clue you into this person's challenge with smoking. Okay, so now we're going to go even further. And we're going to say, all right, we now have our very simple screeners for quantity frequency. That might clue us into some substances we want to ask more about, so maybe we give somebody an audit or a DUDIT. But we really need to know more about this person's drinking and this person's drug use. So now we're getting into gold standard assessments. And I think this applies even to scales of depression or anxiety or psychosis. There are going to be quick screeners, and then there's going to be the gold standard measures. In this case, for drinking, our gold standard often is a timeline follow-back. This is going to provide us with a high-resolution quantity frequency measure. So typically, we'll do either a 30-day, a 90-day timeline follow-back, where we're going to start usually with yesterday and work our way back for a month or 2 months to get on each day how much was this person drinking to the best of their memory. We can use things like days of the week as cues, holidays, life events, etc. What's important here is you can also use this to find out information about what type of alcohol are they actually drinking, what brands of alcohol, what drink size are they drinking. So you might have somebody who comes in and says, well, I only have 1 or 2 glasses of wine. But then when you ask them how big are your glasses, they may say, oh, it's a full-size goblet. Well, it might be a chance for you to provide some education and feedback to that person that shouldn't be considered one drink. So when we talk about no more than 7 or 14 drinks per week, you need to keep in mind that what you're consuming is actually 1.5 to 2 drinks in a given glass. You can also use this for cannabis. You can also estimate the potency of the cannabis that they're smoking, and you can use this to evaluate cigarette use, etc. So that's called a timeline follow-back interview. And obviously our gold standard that we often will get to is a structured clinical interview of some sort, whether that's structured or semi-structured, whether that's a SCID for DSM-5, an addiction severity index, a MIDI, some other form of structured clinical interview. So you can see we've gone now the full spectrum from a very quick screener of 10 items of quantity frequency that then might feed us forward to an intermediate assessment that then might feed us forward, again, to one of these more in-depth assessments if we really want to zero in on someone's unique symptoms or know more about their actual pattern of use. There's also one known as the inventories of drug use consequences. The one that we like is called the YAC, or the Young Adult Alcohol Consequences Questionnaire. This one's a little bit longer, 48 items, but the advantage to the YAC is it gives you 8 individual subscales. So it'll tell you about consequences that this person has experienced related to social and interpersonal problems, risky behavior, impaired control, blackouts, physiological dependence, for example. So if this is something you're interested in, is understanding what sorts of consequences has this person actually experienced and in what areas of their life, you might give them the YAC. And then what you can do is you can provide them feedback that looks like this. These are the 8 items, 8 domain areas on the YAC, and you can provide them with feedback. So this person, for example, was experiencing higher rates of social interpersonal problems as well as impaired control and risky behaviors. But they had relatively minimal problems with self-care, self-perception, or physiological dependence. And you can look at this across your clients and maybe use this both to guide your assessment, but also to provide them with some feedback. going to take a moment. I think we have a question that I can answer here from the audience.
Yeah, so this one's specific to the tools you're talking about. So Kate wants to know if there are any tools available specifically for the senior population.
It's very interesting. We just had a rounds here at St. Joe's with our seniors mental health unit. So the question, if those of you that couldn't hear, was, are there specific screener measures for drug use and alcohol use in the seniors population? And based on what I recall from that grand rounds that we had, is there are not very many drug use and alcohol use screeners that are specific to older adults. And that is somewhat unfortunate because older adults often have a different pattern of use or different sort of consequence profile or risk profile. Alcohol affects them differently with all the physiological changes that happen with normal aging. They also have, more issues potentially with falls and other concerns related to drinking. So I am personally not aware of screeners that are specific to an older adult population. But at the end of the presentation, I do have my email there. If the person that asked that question would like to send me an email, I can certainly do some looking and can give you some feedback on that to see. I'll check with a few of my colleagues here that know more about seniors' mental health, and they might be able to help us with that. That's a very good question, and I think we just need more research, especially with the fact that the population is growing older, and we need to be more concerned about these. We have another question.
Same from Kate. She just wants to know if there's a plan to look into this area specifically for research in terms of seniors.
I think so for sure. I mean, if you think about the changing demographic and sort of with the graying of our society, both in Canada and the States, I think a lot of the funding agencies are starting to be aware of this and are starting to say, we need to better understand the unique circumstances and factors that might contribute. We are doing a study here at the Boris Center. There's a population level study where we have a wide range of individuals that are coming in for screening. I know there's been some discussion here at St. Joe's with partnering more closely with our seniors mental health unit to be more aware of these things. So I would say it's probably on the horizon for sure. And I think the decision makers and the stakeholders are aware of this. Okay. So we're going to go through and talk about another version of the brief YAC, which is just 24 items. And this is a unidimensional assessment of severity. So if you don't have time for a full 48 items, you can do a shortened version. I'm going to move forward here because we're a little short on time and just give you some assessment recommendations. The idea is that, again, you have these three levels. You either have modified assist or quantity frequency measures. You have some more detailed measures like the audit, the QDIT, the DUDIT, the FTND. Then you have your gold standard measures on the right. So maybe it would look something like this. Someone comes into your clinic, you give them a modified assist, and then that feeds forward into some of these more precise measures, and then based on where they screen on those, you might give them the more gold standard measures. Whether or not this works for you or not will really be up to your particular situation. Okay, so now what I want to do is spend a little bit of time telling you about a project that we've implemented here at St. Joseph's Healthcare Hamilton, which is our concurrent disorders screening battery. So our goal with this was to design and implement a standardized screening battery in both inpatient and outpatient concurrent disorders programs here at St. Joe's. So to do that, we developed a battery of instruments that all individuals that come through our program complete when they come for their first appointment. So we get some basic demographics, age, gender identity, and sex at birth. We also get some information on them in terms of their involvement here at St. Joe's. Then we get quick screeners for alcohol, drug, tobacco, and gambling. So a lot of these now should look familiar based on what you've seen previously, except for maybe the gambling measure at the bottom. So they fill these out. And they also fill out a range of screening measures for these mental health indicators. So depression, panic and anxiety, bipolar disorder symptoms, psychosis, borderline personality traits, trauma, PTSD, attention deficit activity disorder, as well as eating disorder. So they come in and they essentially are administered all of these screening questionnaires. Some of them have logic built in, so that if they don't endorse drug use, we don't ask the follow-up questions. If they don't endorse smoking, we don't ask the follow-up assessments, etc. We also assess readiness to change for each of the substances that are endorsed. And we have since moved this into the inpatient unit, and we've divided this into 2 different batteries so that we don't have an increased burden on individuals. We do this using a platform known as REDCap. And so this is an online data capture platform that's efficient, it's streamlined, it's essentially cost effective, and it gives us a full range of controls for data security, archiving, etc. And most importantly, we can build in this branching logic so that we only ask questions if they're relevant for people. So this is just some examples of what the interface looks like on a computer. So this is an example of the welcome screen. The clinician would fill out this information. This is what the audit would look like. So it's, again, these multiple choice questions. They use this on a laptop or a desktop. This is what our drinking days questionnaire looks like. Again, we remind them what we mean by a standard size drink. They report this on this form. This is the NIDA substance use checklist. Again, just adapted from that version you saw previously. This gives you an example of the PHQ-9, or the PHQ depression scale for us. Again, the 9 items of the PHQ, Patient Health Questionnaire. They're rating these on the Likert scale, all these items. We also get functional impairment down there at the bottom. And this is what our protocol looks like. So the client arrives for their initial appointment or group session. A member of our clinical staff will escort them to a cubicle or a laptop. We do have a research component to this, so they provide informed consent if they wish to. They do the battery, it takes about 20 minutes. We export their data, and we then move their data to a macro that gives us a 1-page profile on this person. And I think, unfortunately, I'm not going to be able to go through all the data we've received so far, but I'm going to show you the example of the one-page data sheet. This is what our assessment space looks like. We're able to ensure some amount of privacy for individuals when they're completing this. They're not just doing it sitting in the waiting room. So they complete the online assessment, and a member of our staff exports the data, and we've built an Excel tool that we could provide to you as an example, that all we have to do is paste in 1 row of data, and then some magic happens in there, and what we end up with is a 1-page patient profile or client profile that you can either export to a PDF if you want to save it electronically, or you can print it, and essentially this is what we get. So we get a 1-page sheet on this individual. So if you think back to Susan, she was our 25-year-old female. Normally would have their actual client ID and their initials, but this is mock data here. We get their substance use and addictive behavior profile, so it tells us about their alcohol use and misuse, their audit severity, how much are they drinking. If they're a smoker, how much are they smoking? What's their frequency of substance use and their severity of substance use. But also we get their motivation to change on each of these substances, and that's based on their self-report. So that'll clue us into what they're using, how often, how severely, and then are they ready to make a change. Then for their mental health status, we get whether they screen positive or negative, as well as their percent scale max. So did they score very high on that, or were they just kind of right near the threshold? Now we can provide this to the treatment team, and they can use this to guide their assessment and all of the treatment that they're providing. So I just want to show you some very quick findings that we found so far. This is just some of the demographics. We've now completed 203 outpatients and 40 inpatients. And what we're finding is that our individuals are reporting high levels of alcohol use that you might expect for a concurrent disordered population. We do see some sex differences on some of our measures, but not all. We can also look at our inpatient versus our outpatient unit. This just kind of shows you a breakdown of what our audit scores look like. So you can see anywhere from 42 to 52% of our population are screening in the high range on the audit. This is interesting. This is the kind of information we can gather from the readiness to change, which is essentially, are they trying to change, are they ready to change, are they not ready to change? And you can look at how these things play out over time. I'm going to skip forward a little bit. One of the advantages to the NIDA Assist is that you can actually look at breakdown by substance, their quantity, frequency of use, and you can plot it in these ways so you can see for this individual or across your program what substances are being most used most frequently, etc. Let's skip forward a little bit. This also can give you a barometer of where your program is or your individual in terms of their motivation to change. So are they in the green zone, are they in the red zone, etc. And then you can also look for the mental health scales. Where are they scoring in terms of the mild, moderate, severe, positive, negative, etc. this is the level of data that we can achieve by doing this type of a focused screening. And then the future for us is to use this information to steer people into individualized care paths. So whether that's based on their level of alcohol involvement, their tobacco involvement, their gambling, their mental health, unique mental health profiles, that might eventually help us to steer them toward particular groups or particular treatment services that we have that might better help them. So one last thing I want to wrap up with is some of the challenges that we have encountered. And that is, what are we learning in terms of challenges that we've experienced? So one of the main challenges that we've encountered is how do we actually implement this from a scheduling standpoint? So the battery takes about 20 minutes. So how do we get people here in advance of their appointment so that we're not interfering with the scheduling of sessions with their treatment providers? But we want to get this information. So that's, we've tried to encourage people to come 15 to 20 minutes early for their appointment. Or if they're on the inpatient units, we try and find them in between programming so we're not interrupting. I'll take a pause to take a question from the audience.
Yes, so Derek has a question. Could the gain as supplement or replace some of your existing screeners, given that it is concurrent disorder focused?
Yeah, I think so. We are also in some of our situations starting to look at the GAIN SS, using that as well. My understanding of the GAIN SS is it's primarily going to be used. No, that's the RAI. That's for residential, right? Okay, so my understanding is that the GAIN SS is primarily used for people that are going to be going to residential treatment. I may be wrong about that. I think our assessment is not meant to replace other things, but what we're able to do is provide maybe a supplement to the GAIN SS, but we are actively looking at that. And we are using it in some of our settings here. So, for example, Womankind Addiction Services and MASH here are using that measure. But what we were trying to do was implement this really before the GAIN SS was rolled out system-wide or VIN-wide, and so we wanted to do our own in-house approach. But I think some of these measures could be folded in or taken out because they're accounted for by the GAIN SS. That's a great question. So getting back to the challenges and lessons learned, another thing that we often struggle with, especially when we moved from outpatient to inpatient settings, was we had to be concerned about the level of functioning and psychiatric or cognitive impairment for our individuals, and whether or not the language on these screeners was going to be understandable to our clients, and whether or not we had to be concerned about lack of understanding and how that might affect the data. So we've done some pilots with these measures with various people of different severity levels to determine what the right length of measures and the complexity of the measures. Another challenge that we have is determining the appropriate cutoffs for what it means to screen positive. And an issue that we have is that many of these measures, like the PHQ, for instance, were developed in either community or primary care settings. And our population is especially on the inpatient, is a very acute population in terms of their level of impairment. So what we don't want to have happen is have 90% of our population screen positive because the cutoff values are not based on the level of severity that we're working with. So we are working toward getting our own normative data to hopefully inform more appropriate cutoffs for what it means to screen positive. One thing that's also useful is, in addition to looking at positive versus negative or high, medium, low, you could look at percent of scale max, which will tell you whether somebody is really truly at the highest end of the measure or whether they're kind of in between or whether they're at the low end of the measure. And I think our biggest challenge that we're really working toward right now is increasing the value of this screening to stakeholders. We see the value of it from a data standpoint, but we want to make sure that we're maximizing the uptake and the use of these patient profiles by our clinical staff and the treatment team. So we're working with our stakeholders in terms of having back and forth conversations about what aspects of this screening battery are useful to you, which are not, how could we improve it, how could we improve the format or the information we're providing to you. But also we have to be aware of the fact that our clients are going to want to know what this information that they're answering, what is it telling us? They want to know, well, what do my responses tell you? And we're trying to figure out the best way to provide meaningful feedback to clients. Because providing them with a one-page data sheet with percent scale max and cutoffs may not be particularly relevant or even understandable to somebody who doesn't have clinical training. And so we're working on ways that we can provide meaningful feedback to clients to help them better understand their situation. And then also moving toward identifying these appropriate care paths. Again, if we could use this as a way to identify and match people to programming or groups or other sorts of resources that are going to help them with their unique situation, I think that's a strategy we want to move toward in the future. One more question from the audience?
Yeah, so we kind of touched on with the clinicians, but maybe you can talk about like the Brash. So Julia asked, do you feel that clinical staff see the benefit and value of the work you are doing and see it as needed rather than just nice to do?
Yes. So the question is, have we received any formal feedback from our clinical teams as to the value of this? Are they actually using it? It's a little early to say anything for sure on the inpatient side because we just rolled this out within the last couple months. But we do have a dedicated concurrent psychiatrist, Dr. Jennifer Brash, down in our outpatient clinic. And we did a brief kind of huddle with her to ask her about what she thinks. And she's talked about the value of this. She's given us the feedback that she understands that this is not meant to replace her clinical interview and her careful diagnosis and assessment. But she said it gives her a roadmap. She says it points out things that she needs to ask about or things that maybe she doesn't need to ask about. And she's even said that it has raised a few eyebrows about things that she maybe didn't know about the person based on the information she had. So we are getting some feedback from our stakeholders that they see the value in it. But again, we need to make sure we're moving past just the, nice to know, just give us some data kind of angle, and we want to make sure that it's actually having meaningful impact on assessment, diagnosis, treatment planning. So we're getting there. But we've been doing this, we're doing outpatient now for about a year, and we're now getting to the point where we have about 200 people where we can actually start looking at what's the uptake of this, what's the use of it, et cetera. We see the value in it, but we want to make sure that we're doing whatever we can to maximize the value to the treatment team. Okay, so we're just about out of time, so I want to give some take-home points for you as we wrap up. So we obviously know that concurrent disorders are complex and often require individualized screening and care. And the important take-home point is that there's different levels of assessment depending on your unique needs and your resources in your particular programs and your particular context. We believe that standardized screening assessments can be implemented with minimal burden and cost if you pick the right measures. And many of these are very easy to score and relatively easy to interpret, with maybe a little bit of upfront work if you want to automate that process. And most importantly, we think screening data, in addition to being useful for the individual client, can also provide you with an ongoing census of patient population that can help you to get a barometer for what kind of your census looks like, and that might help you to design new programming and new strategies. So with that, we thank you. Candace is going to come back up and just give a really quick wrap up here. My email address is on the screen if you have any questions, if you would like copies of any of these measures, if you would like to learn more about our battery, please feel free. We've uploaded a few things onto the webinar. We have a PDF of a recent publication from our group. We have a PDF of what our client data sheet looks like, as well as a PDF of these slides. So all of the information that we presented will be on there. Please get in touch with me, and thank you, Candace, for the invitation to participate. And I hope to hear from some of you with some more questions. So we're going to wrap up.
Thank you all for attending. I hope you found today's webinar useful. As I mentioned before, we offer educational sessions both in person and online under our Foundations, Intermediate, and Advanced webinars. For more information and up-to-date webinars, you can visit www.concurrentdisorderstrategy.com. I hope you enjoyed today, and we'll see you next time. Bye-bye.